Good afternoon, and welcome to today's Protect Our Province BC briefing on December 1st, 2021. I'd like to begin by recognizing that we're broadcasting from the ancestral, unsurrendered, and unceded lands of close to 200 Indigenous nations on whose land we call now British Columbia. The over 12,000-year history of stewardship and kinship of First Peoples of these lands need to be acknowledged as the leadership that we seek today. I'd also like to just remind everybody that Protect Our Province BC is a grassroots organization of physicians, healthcare scientists, healthcare policy specialists, community advocates, and nurses, and we're working together to help BC stay safe during this pandemic, as we all have been living for the last 21 months. We are advocating for evidence-based policies, and our goal ultimately is to end this pandemic. My name is Dr. Amy Tan, and I am coming to you from the ancestral, traditional, and unceded territory of the Lekwungen-speaking people, namely the Esquimalt, Songhees, and Wasanic First Nations. And I wanted to welcome you to today's briefing. And next slide, please. Our topics for today are going to focus on three things. We are going to talk about how BC is not post-pandemic, how BC's COVID policies to date have not been evidence-based, and how and why. And that we are advocating that BC needs to start following the evolving science and take preventative measures now. Next slide. I have the distinct pleasure of welcoming Dr. David Fissman to this briefing, and we're going to have a conversation with him. I don't feel like he needs an introduction because I feel like most Canadians have been following along, especially on Twitter, with regards to Dr. Fissman's takes and analysis of the evolving COVID-19 situation, which, like I said, I slipped up and I said it was 21 years because in some ways it feels like that, but it's been 21 months. So I would like to introduce and welcome Dr. David Fissman, who's a professor of epidemiology and an infectious disease specialist from the University of Toronto.
So I'll just jump in quickly and correct my bio there because that's a bit old. I no longer work at University Health Network in Toronto. I do some full-time stuff at some other places, but I don't have any connection to UHN. Okay. But that's, yeah, I think that's on the internet still. So thank you so much for having me. I mean, you're one of the people I sort of feel like I'm friends with, even though we've never met.
Exactly.
Been interacting, and I think very much on the same page for a number of months now. BC is a special place. It's historically, I think it's been the place where we've hit the high watermark for good, smart public health in Canada. And so while I don't work there, I feel invested because I don't think that British Columbia is doing as well as it might. I also think that, and I had mentioned this before when we connected a few days ago, that I just want to highlight the fact that I'm able to sort of talk a bit about what I see as the limitations of the pandemic response in BC. On the one hand, I'm held back by not having an intimate knowledge of what's going on in BC. But on the other hand, I know that there are colleagues in British Columbia, in public health, in clinical medicine, who have concerns, but don't feel that they're able to speak out for fear of sanction. And so, I'd very much like BC to be in a situation where it would be much easier for colleagues over there to talk about their province rather than having to sort of, you haven't actually shipped me in, but you sort of shipped me in because I can speak my mind about this.
And we're so grateful that you're willing to share your expertise and your analysis so that we can, again, as our main purpose is really about having British Columbians get scientifically based information to be able to make good decisions in their daily life, but also in their workplaces and beyond. So I think if it's okay, we're going to start with our conversation. And I think the one thing that has been nonstop chatter on Twitter, on the news, is the new variant of concern, Omicron. And we chatted a couple of days ago, and at that point on the weekend, you had said, at best case scenario, this is hopefully a fire drill, but I have a feeling it likely isn't. So I was just wondering, it's been a couple of days now, and just was hoping to get your sense of where you think things are at, knowing that it is an evolving situation, hour by hour.
It absolutely is. So we have this variant that's emerged. There are a couple of funny things about this. It's it's called Omicron. They sort of leapfrogged over 2 letters in the Greek alphabet. They leapfrogged over new, because I think they probably wanted to avoid Abbott and Costello kind of jokes where someone says, "What's the new variant called?" and someone says new, and they say, I know it's new, but what's it called? And then, of course, Psi, which is spelled XI, which it has the same spelling in English as the name of the Chinese premier, which I suspect would have engendered some pushback. So they've leapfrogged those 2 letters, and Omicron it is. So what this thing is it's a weird variant that's kind of initially been identified in South Africa as they've started to. South Africa's in the summertime now. They've been through some big waves. COVID had been pretty quiescent there for the last month or 2, and they've started to see rising case counts. And thanks to very good labs, they're able to sequence the virus and see that this new virus is like nothing we've seen before. In particular, it's just chock full of mutations. It's almost like the virus read the literature. It's chock full of mutations that either are known to enhance transmissibility and virulence or haven't been seen before. I'm going to screw this up. I think it's called Q498R. That's never been seen in a virus in the wide world before, but has been written of as something that if that happened, that would really, make the virus more effective. So it's sort of got all these things. Bursts onto the scene. There's been a lot of great work, including great work from BC, from Dr. Sarah Otto, who's over there, looking at the growth rate of this thing in South Africa. It does look like it's more infectious than Delta, which is already very infectious. The difficulty, as other people have pointed out, like Christian Altus, who's a modeler in Switzerland, has pointed out that this explosion can represent increased infectivity, but it can also represent immune evasion. So, the virus doesn't really care how it gets susceptible people, whether it gets them, because they've never been vaccinated, or it gets them because the virus itself changes in a way that evades immunity. Both of those things push up the reproduction number, and it's hard to tease them apart. But there have been some informed suggestions that this explosive growth in something that has a very, very different spike protein from what's gone before, that's one of the knobs that sits on the virus's surface. It's not inconceivable that this makes vaccines work a little bit less well. So since this burst onto the scene, of course, a lot of countries impose travel bans on African countries. Looking at this, as people have looked at kind of the family tree of this thing, it's been suggested that it probably hasn't been around for more than 2 months or so. So it's quite a new virus, which is weird because our Canadian cases, for example, were imported from Nigeria, which is very far from South Africa. A Belgian case was imported from Egypt, which is very, very far from South Africa. So it seems to be all over the place in Africa, or at least at first seemed to be. And now we're learning that it's actually transmitting in the community in the United Kingdom. And I think there's a physician named Jorge Caballero who did a really nice thread on Twitter yesterday, looking through different sequence databases to say, well, maybe this thing has actually been in other places much earlier, maybe as early as September, maybe as early as August, including in North America and including in Italy. And if that is the case, then obviously travel bans imposed on African countries start to not make a whole lot of sense, although you might still say, well, it's a new threat. We want to beef up what we're doing at the borders with testing and quarantine. But yesterday there was a piece published in an Israeli media outlet, unsourced, in terms of who said this. Presumably the source is someone in the Israeli government, mentioned some early work that's starting to come out of European Union and South Africa, suggesting that in fact vaccines do work quite well against Omicron. They're quick and dirty estimates of vaccine efficacy. Now they're looking at 3-dose vaccinated people. Seems to be very efficacious after 3 doses, which obviously is the thing for us to consider in Canada. But that in unvaccinated individuals, it looks like it makes them sicker than even Delta, which already makes people sicker on average than original variant Wuhan. So, in terms of what this means for us, well, vaccines still good, get vaccinated. Pediatric vaccine still good, get the kids vaccinated. And then maybe something that we can talk about is use all this science that we've left on the table about how COVID transmits, because this thing's clearly mega airborne. I mean, it infected someone right across a hallway in a Hong Kong quarantine hotel where both people, I think, were double or triple vaxxed.
Right.
Now, one of them was apparently wearing one of these stupid masks with a valve in it, but leaving that aside, the thing
Yes.
blew out into the hallway and
Right.
so forth. So yeah, it's airborne
Right.
as all COVID is.
Right.
So we need to start using those tools to keep ourselves safe, because Canada has actually been doing very, very well the last couple of months as a whole. And maybe we can talk about what places have been doing better than others and maybe why some of that is happening.
That'd be great. Thank you so much. And I think you very much touched on things that we hope to cover throughout this broadcast. One of the follow-up questions I had for you was, you mentioned that Twitter thread about perhaps it's been around since September. And I think some of looking at that thread, it said, is that actually good news? Because it's actually been undetected for so long that perhaps it's not as scary as we think. And wanted to know your thoughts on whether or not it was too early to tell at this point.
So A, it's too early to tell, but B, you could interpret that in a positive way. This hasn't kind of, if this is in lots of different places and lots of different places that are doing relatively well, then that's a bit less concerning. Now, that said, Europe has been doing terribly the last 6 weeks, and we've all been attributing that to premature declaration of victory and getting rid of, mask mandates and doing kind of the best summer ever thing. But I think something that one then starts to wonder is, well, was that all just getting rid of masks? Is some of this flying under the radar in Europe and in the European Union? Because Europe's really been an outlier over the last 6 weeks. Most of the globe has actually, COVID's been looking better and better and better. Europe, the European Union within Europe has been looking worse than the non-EU countries, which is interesting because it's actually the richer places are doing worse.
Exactly.
And then the United States is the other place that's sort of a global outlier. And the United States is, as I think we've learned these last few years, is sort of its own thing.
Yes.
All
right. No, so I think the main takeaway so far is we need to sit tight. We need to continue to watch how this evolves on an hour-to-hour basis, day by day. But the bottom line is get vaccinated. Get your kids vaccinated right now. There's early signals that, the vaccines are still the best thing that we have for this. And so we need to use the tool that we have for that. And we're going to talk about the other mitigation factors because COVID is airborne. And we're going to talk about all of those specific things like testing and airborne. But the first thing I wanted to talk to you about specific to the BC scenario is that yesterday there was a lot of chatter because at the provincial presser for COVID-19 at the latest update, it was described that COVID-19 is endemic in BC. And I thought it was really good timing to have you on the next day because we could actually have a conversation about this. Because from my estimation and my understanding of what endemic means, even though it's not a marker of severity, it's really about how much it is affecting daily life for the general population. How much, yes, it is everywhere, but how much is it affecting daily life for everybody, how much effect on the healthcare system is happening. Those are factors that have to be played into this when you declare something is endemic. So
Yeah.
could you give us a working definition of what you see as endemic and the criteria for that?
Sure. So endemicity. So first off, what makes a pandemic is widespread susceptibility. Lots of people haven't, you know, haven't grown up getting immune experience with this particular virus. It's a new virus. That means that at baseline, everybody was susceptible. And over time, what happens, and you can see this globally in the global reproduction number, over time, that reproduction number is getting pulled down further and further and further towards one. And when it's one, that means each old case makes one new case before it gets better. That means it doesn't go away, but it's also not into exponential growth. And that's actually, from an infectious disease epidemiology point of view, that is a functional definition of endemicity, would be the reproduction number hovers around one without doing anything, right? If the reproduction number is below one without doing anything, we have a disease that can be eliminated. And that's what we talk about as herd immunity. I mean, both of these things have been ridiculously abused, these terms, by folks who frankly shouldn't shouldn't be within 30 feet of this terminology because it's irresponsible. But that's what herd immunity is when we have a reproduction number less than one without doing anything. And endemicity is when it is one or around one, and it typically will oscillate up and down around one without doing anything. So I don't think BC's there yet. Will we get there over time? Yeah, I think we will. And I think we may actually get to something like herd immunity at some point in Canada, with a kind of a combination of people who decline vaccine having immune experience from prior infection, plus vaccinating on top of that. We have herd immunity to highly infectious things like measles, has a reproduction number of 12 or 15. But it does take time to get that immune experience. So I think we'll get there. I don't think you're there yet. I'm not aware of the quote in terms of how exactly this was phrased. Unfortunately, COVID's probably not going to be eradicated. And I say that for two reasons. One is we have diseases on planet Earth that we should be able to eradicate. That means make go extinct, like measles and like polio. And we have very good vaccines, and we've been trying hard for a long time, and they're still around. And we don't have any animal reservoirs for those diseases. It's just humans. For COVID, we have now a highly infectious disease because every one of these variants seems more transmissible than the last, which makes herd immunity harder to get to. And then we also have the whole issue of it being kind of an animal virus that got into humans, but that seems to be very promiscuous in terms of which mammals it will infect. It seems to be quite happy to infect, deer and tigers and house cats and dogs and mink and blah, blah, blah. And in fact, Christian Anderson, who's a virologist in California, suggested there's this weirdness with Omicron that it's missing its family tree. Somehow it's come out of nowhere.
Wow.
And genetically, it's very far from what's gone before. So how do you explain that? And I mean, I don't want to go down that road necessarily, but something that he suggested is, well, maybe it went off into an animal reservoir for a while, mutated there, and it's come back. Maybe I don't know. But that idea over time, if we have animal reservoirs in deer and bats and dogs and cats, it's going to be very hard to eradicate it.
Right. Wow. Okay. So, interesting question that has been posed is, has there been any place in Canada so far that has hit that endemic phase in your estimation?
I don't think so, because what's happening is there are places that have de facto eliminated, like locally made go more or less extinct COVID for long stretches of time, but that's been via public health action. So I think to me, endemic means it would be chugging along at low level with life very much back to normal. The places that have really shone in Canada, everywhere's had kind of their moment and then also had their periodic comeuppance. The places that have really done remarkably well have mostly been the Atlantic provinces and the Canadian North. And I think in terms of the North, the folks who work up there know how high the stakes are with something like this, that there's not a lot of ability to get people south for care.
Right.
That you do have historical, well-recognized historical challenges around things like housing and crowding. If we're going to talk about airborne,
Yeah.
I think it's relatively controversial to say tuberculosis is an airborne infectious disease. We've got tuberculosis incidents in northern First Nations and Inuit that are 40 times higher than the country as a whole. So we know we have vulnerability there, and I think to some extent that may have motivated folks working in the north to really keep a lid on COVID. They've had setbacks. Yukon's had setbacks. Nunavut, Northwest Territories, but they keep reeling it in. And as of this morning in our data, we had 8 cases from the north. I think most of those are probably in Yukon. But those places as a whole, you look at them per capita, they sort of don't even show up on the graph. The Atlantic has also been remarkable. The somewhat outlier, but still has done very well, is New Brunswick. But
Right.
Newfoundland, Nova Scotia, and PEI have all done phenomenally well. I mean, PEI occasionally they'll get a little cluster. They have one in a place called Prince County right now. They're controlling it. Nova Scotia has, they've got some, I think they're basically religious kind of farming communes in northern Nova Scotia that are kind of effectively congregate living settings. So they've got an outbreak there in northern Nova Scotia right now. Newfoundland had no cases yesterday, which has been, and they have setbacks, and then they reel it back in, and then they're okay. But it just, it's been attention to the science. It's been use of available tools. They know that there's vulnerability because people travel from other parts of the country into these provinces, and they have taken testing and quarantine very seriously. Nova Scotia's, done a remarkable job of actually using the rapid tests that the federal government
Yes.
procured. I mean, they've done
Absolutely.
mobile testing. They go to you. They've done school testing, and it's made a huge difference. So I think those are, I mean, as they say, health is provincial in Canada, and because of that, I think you see the full gamut, where we've basically had kind of a Texas-style COVID response in Alberta, as you know well, all the
Yes.
way to something more looks more like New Zealand in Nova Scotia and PEI. So there's a lot
Right.
of range.
Yeah, and I think one of the challenges as, Canadians following this, especially in this age of social media, is how do we actually compel provinces to, decrease the dissonance and the strategies so that we actually come, because we are a country. So let's actually not be, I think, just inherent to where you live
Right.
specifically. So I
Right.
think it's really
And
important.
I don't think it's fair, if you're a Canadian citizen, that you should be looking down the barrel of the sort of stuff that happened this summer in Alberta and Saskatchewan. That's
Right.
not fair. An accident of residence shouldn't condemn you to kind of suffer under terrible public health leadership. So
Yeah.
I don't think that's. I know that I know it's really, really complicated for the feds to step in. Beyond sending the military sometimes in some situations. But yeah, it is something that I think has been striking to a lot of us, is how can you allow the floor in terms of what's a competent response to be so low?
Right. Right.
Um,
And you're speaking about local milieu, and the fact of the matter is, in BC, we actually have, I mean, one would say 3 crises with the opioid poisoning epidemic, COVID, and climate crisis. We have right now, we're in the throes of 2.5 weeks of storms and massive flooding, which, with evacuations and people living in shelters and congregate settings, and losing their homes and their livelihoods, COVID's still here. And so I think, we put out a survey, Protect Our Province BC put out a survey just before the first storm 2.5 weeks ago. And we had so many healthcare workers write in about how they are so burnt out,
Right.
and they are worried not just for their own well-being, but for the well-being of British Columbians. They are worried that healthcare will never, at least in the immediate future, never be at the quality British Columbians deserve. And they said the healthcare system was broken before. It definitely is broken now. And then the storms came and we had massive flooding and evacuations. And so I think this is a testament to, we talk about endemic, we talk about Omicron, and I think this is the constant threat right now, that we need to do what we need to do to be containing this, because I think I said this on the weekend to you, we can't make immediate changes for today, for a week from now, for climate change, but we can for this virus, and to help with the overwhelmed healthcare system.
Totally agree. I mean, so a couple things I'd say there. I think BC, like other areas in Canada, although BC is really getting it with both barrels at the moment, is looking down the barrel of really a few major threats simultaneously. We have the pandemic, which is nasty. We have climate change, which is, as you say, going to be a multi-year threat. And I think we're starting to see, I mean, the frustrating thing is someone who's been interested in infectious disease and climate change for a while. So I've, been reading the IPCC documents since the early 2000s. None of them have changed. I mean, in terms of what they say is coming, it's just the confidence intervals get tighter.
Right.
And then I think we're seeing another really important threat, which I think is born of kind of extreme income inequality in Canada. I think we've followed the U.S., and I think it's left a lot of people behind, or certainly made a lot of people feel like they're left behind. That has, created real dry tinder for social division. And I think on top of that dry tinder, social media is now lighter fluid. So I think that makes all of this stuff harder, because if you have folks who are being divisive, potentially even intentionally being divisive, with division as their goal, in the face of these crises, it gets very challenging. I think the important tie-in with climate change, in addition to, the fact that it just makes everything harder right now when your province, big swaths of your province are underwater, is one of the things that makes COVID so challenging is you can see this exponential growth process happening, but the effects are going to be lagged. Right. So what political leadership means in that context is you see the cases going up, but the hospital beds aren't full, the ICU beds aren't full, and you don't want to do anything because you don't want people to be upset with you because the hospitals are there's still room. Well, because of the lags built into this system and because of exponential growth, you have to be able to act based on what is around the corner, even if it's difficult at this moment, because you haven't hit the iceberg yet. You know where the iceberg is, and that requires real political leadership. And I think that is the situation with climate change, just to the nth, right? We know what's going to happen, but it's lagged. And if you react when it's happened, it's too late.
Absolutely.
I think there is a parallel there, very much.
Okay, thank you. So we're going to play a clip from an ICU physician now who works in BC, and he was interviewed just this weekend as well. And we just want to show this clip because I think it really speaks to, again, the crisis that we're dealing with in British Columbia, and how we really don't have much more to bear, and we really can't. And so how do we, and then that will take us to, the actions that we're calling for.
Right.
So if I can ask the tech team to roll the video, please.
This fourth wave has not stopped. In terms of supporting other health authorities that have been overwhelmed, like the North, and in dealing with patients locally, we continue to have a significant burden of COVID disease in the hospital and in the ICU. This is not something, if one becomes seriously ill, that recovers quickly. It takes a long time and therefore consumes a great many resources in the hospital. As a consequence, our ICUs continue to be essentially overwhelmed. We're functioning, we're still maintaining capacity to admit, but it is exhausting, and morale continues to be good despite an incredibly frankly, excessive workload that's sustained. People are done. My fear is that once this epidemic wave or the pandemic settles down, that I think many nurses are going to be looking to do other work. They are exhausted. At one point last weekend, each of our wards had only one RN on it, on them, because people had called in sick. They're tired. I mean, in terms of the intensive care unit, that's exactly the problem, is that we have a steady stream filling a reservoir and really just a trickle going out. It only takes 2 or 3 a week that are going in and 0 to 1 that are going out for it to become overwhelming. Even as COVID spreads through the vaccinated population, we know that vaccines are 90% effective. That means they're 90% effective in preventing serious disease. But if 10% of the Canadian population becomes ill, vaccinated population becomes ill with COVID, and 1% of those require hospitalization, we're talking tens of thousands of people. Mm-hmm. That's going to overwhelm our system. So even if it's just a tiny percentage that become ill, the impact is huge when they come in, but they don't leave for weeks. Mm-hmm. And it just sucks up these resources and is going to have a huge impact on access.
Thank you. So I think we can't underscore enough right now our dire concern about the healthcare system, not just in terms of beds, but in terms of the healthcare workers, the skilled healthcare workers that are needed to treat all these patients. I just wanted to give you a quick snapshot right now. We in British Columbia, we have about 5 million population. Ontario has about 3 times the amount, so 14.5 million. And we are averaging in BC 350 new cases a day. We had 30 deaths last week. And we're averaging about 4 deaths a day right now. And this is the thing, is that, you know, we have 300 in the hospital right now in BC. Ontario has the same number, 294. And they're 3 times population. So I just really want to underscore, you know, we can't be sustaining these levels. And so I'm going to ask for the next slide, because we're going to talk about what is we're calling for actions, but we really want to underscore that we're not asking for lockdowns. In fact, 21 months in, lockdowns would be actually a failure, because we have the tools. We know what the science is telling us with regards to the non-pharmacological interventions that we need to bring down transmission so that our hospital system and our healthcare system is not overwhelmed, not just with COVID, but with any healthcare that any British Columbian may need. If you unfortunately were to get into a car accident tomorrow, God forbid, would there be room in the ICU for you? Not just the bed, but the healthcare workers that are needed to care for you. And this is where we're coming from with regards to asking for these types of policies to be brought up based on the science. Next slide. So we're asking for a vaccine plus policy that's driven by not just only the vaccine, which is a very important foundation, but to continue widespread testing, tracing, and isolation still. We should be having better masks, so N95 masks, because as Dr. Fissman has said, it is airborne, and we need to clean the air with HEPA filters and improve ventilation. Part of this is also, as we gather over the holidays, Hanukkah has just started. There are going to be other winter holidays happening in December, is rapid tests. We need access to these rapid tests so that people can actually gather safely. And we know it's important. We know it's important for humanity to have some sense of connection during these very trying times, but let's make it safer then for everybody. Next slide. This is just, I'm sure you've seen this representation before. This is the Swiss cheese model to show that we need multiple layers, all working concurrently at the same time. And so the next slide, this is just a list to show all the things that we're asking for give us access to the rapid test like Nova Scotia is doing, and they're shipping out 55,000 this week alone to people, and talk about the fact that COVID is airborne and we need better masks and N95s for healthcare workers especially, but that all public members actually know that once they're in an indoor space sharing air, they must wear a good fitting mask to protect themselves and others, even vaccinated or not. But still remember to get vaccinated and make sure places like schools and workplaces are protected as safe as they can be. We don't want them to shut down, but we want them to be safer. With that, we're going to turn to some questions, and I'm going to ask Dr. Fissman to rejoin me. And so we have some questions from Twitter and beyond. So the first question we have is from Nicholas Pescod from Czech News. What do you think of the government's decision to discourage post-secondary institutions from notifying the public, faculty, students about any potential exposures on campus?
I mean, what would be the possible rationale for that? When I look at reporting from Atlantic provinces that are doing really well, one of the things that they do is they let people know, it's in the newspapers, it's on TV, where did the exposures occur? Because what you want is, Zeynep Tufekci, who's this wonderful journalist in New York now, made this point early on. When we have a disease that grows via super spreader events, what that means is that most people who are infected got infected in a super spreader event. So you're actually much less interested in who they contact moving forward, because some cases are going to be dead ends, than you are, where did they get it? Where did the case come from? Because if you know where that case came from, you're going to find a whole bunch of other cases that got it in the same place. So, I mean, this just, I'm trying to wrap my mind around this in terms of what the possible rationale for that would be. But that just, what do I think of it? I think that's bad public health practice. I think that, and this is a bigger theme, I think, with BC, is when it's public health, right? The team is the community, right? And you may have public health authorities who are sort of supposed to be captaining this team, but a lot of this stuff has to get done by the people on the team, which is the public. And the people on the team can't do stuff if you won't inform them. People have no ability to use available tools to protect themselves if they're kept ignorant of risk. So I'm sorry, I don't have a more nuanced answer, because and I'm sure someone from BC CDC can say, well, we're going to do it because of X, Y, Z. That just sounds like brushing your problems under the rug, which doesn't work historically especially well for communicable disease. It tends to come back and bite you.
Well, I appreciate your candor. We had Dr. Lisa Barrage on one of our other briefings, and she actually said, rapid tests and letting the public know where the infections were was about public empowerment and getting them to be part of the team to do what is needed.
As is messaging on aerosol, because everybody can understand aerosol. It's Canada. We can see our breath 5 months a year, right? We know what aerosol is. And if you tell us that's how this spreads, people can fill in the gaps in terms of how they should behave in different settings. But it's disempowering to keep the truth from the public. And I'd also add, not to be too much of a firebrand here, but you pay for that data, right? This whole public health system is funded by your taxes. I mean, for heaven's sake, surely you have a right to know what's going on in your community. It just strikes me as extremely paternalistic. Some of this stuff wouldn't be acceptable in clinical medicine, and I don't think it should be acceptable in public health.
Thank you. So our next question is from, I believe, somebody that you know, Penny Daflos. Is it Daflos or Daflos? I'm sorry.
It's Daflos, Greek
Daflos,
pronunciation.
sorry.
Yeah.
Okay. And she is a reporter from CTV. And please, thanks for joining us, and please ask your question.
Thank you so much. Yeah, Dr. Fissman, I know there's a lot of uncertainty around this Omicron variant, and I just want to know, how much of an advantage would it need to have over Delta to start causing problems, whether it comes to hospital capacity, whether it comes to the risks of a fifth wave as people start to get together indoors without a lot of aerosol education during the holidays? So I'm just wondering, how much extra does Omicron have to be worse than Delta to start getting us into trouble?
The problem with these things is it doesn't have to be very much worse. In as much as there's some degree of cross-protective immunity, what we've seen repeatedly now in Ontario is, first Alpha displaced original variant, Wuhan variant COVID, and then Delta just made Alpha go away. Now there's a lot of moving parts. So Delta is more virulent and more infectious than Alpha, but it also kind of appeared here over the summer and appeared when we were well into our vaccination campaign. So there's a lot of different moving parts going on. The stuff from South Africa really does make it look, and Sarah Otto, again from BC, has a couple of estimates that range from 10 to 25% more infective per day. And when you're talking about an exponential growth process, there are two things. One is I think BC's reproduction numbers below 1 right now. So that 10 to 25% increase in growth can tip you back into epidemic growth. And the second is because it's exponential growth, these relatively small percentages, it's like compound interest. It can really rev up growth a lot. So it is a worry, and I think I'm clearly not the only one who thinks so, because I'm not the one who shut down the flights out of some different countries. And I think for the feds to take action that quickly, you get the sense that they appreciate how dangerous this could be, and maybe we'll duck a bullet, and I hope we do. But small changes make big differences when you're talking about exponential growth.
Do you have another question?
Yeah, just since I'm here already, I know, Dr. Fissman, you've been talking on Twitter a lot about how it's starting to look like this may be a 3-dose series for the vaccine. And just considering that there are questions around Omicron right now, I just wonder if people should start kind of in the back of their head thinking 2 doses isn't fully vaccinated, that it's when they get that 3rd dose that they should be a lot more comfortable, and maybe a little bit of caution in the meantime wouldn't be a bad thing. Like, is that how we should think about this going into the holidays?
So a couple of things. I again, kind of out of the loop. So I'm not in the loop enough to understand why some Canadian experts seem to think that we should avoid 3rd doses when we have them in country and they're going in the garbage can, when other countries are using them. And other countries are using them because they had resurgences after double dosing. It's very nice if our Canadian extended interval maybe worked a little bit better. But I don't think in the face of a public health emergency you'd want to put too much stock in that. I did put a graph up on Twitter today showing what our Ontario estimates are, this work with Ashley Chute, on risk of breakthrough. And what you can see is that 2nd dose of vaccine, people are remarkably protected. So the vaccine efficacy between 4 and 6 months protecting against breakthrough relative to before people were vaccinated, it's about 100%. It's awfully close to 100%. It's not 100.00. But then it bounces back down to about 85% after 6 months. And that's as far as we can go, because we don't have, indefinite follow-up on people. But I think in as much as they work very well, 2-dose series work very well. Other countries have told us, that vaccinated ahead of us have told us, we needed to go to a 3rd dose. And I think we see this again and again and again, where there's this desire to say, well, maybe Canada will be different. Canada's never been different. One of the nice things about living in a connected world is you can say, oh gosh, the Japanese really have this tape. What are they doing that we're not doing? Oh wow, the Israelis had a big surge and they added those 3rd doses and it went away. Maybe that's a good idea. You don't have to wait until you have the disaster and then react to it. So yeah, I think. And sorry, I seem to be incapable of a concise answer, but I think when you look at a bunch of viral pathogens against which we vaccinate, hepatitis A, hepatitis B, HPV, a lot of these things have had 3-dose regimens where the timing is 0 months, 1 month, 6 months. So it seems to me pretty unsurprising that COVID would be the same. I'm not an immunologist. I can't tell you why that 6-month dose, that 6-month reminder for your body is so important, but it seems to be that for other diseases too. And as I say, we have the vaccine supply and it's getting thrown out.
Do you have any other questions, Penny?
I don't want to hog the time
Okay.
from my colleagues.
Okay.
I know there's
Thank
other
you.
people out there, so thank you
Okay.
for the time.
Sure.
Thank you so much. And I think, you make a really good point that Canada is throwing out vaccines. And I think that's actually morally really hard to reconcile because of the vaccine equity issue that we know that with Omicron, we know we need the low middle income countries to get their vaccines, and we need patent release and all of those things. And they all have to happen concurrently. We need to get vaccinated and be safe in Canada, but we also need to look at the vaccine equity, and we need to do our part, which is meaning that we need to get our vaccines out and not throw them in the garbage at the minimum.
I agree. It's not like a noble thing where, we didn't do third doses because parts of the world need first doses if you're throwing out third doses.
Yes.
That's not helping anyone.
No. So thank you for underscoring that. So the next question I have is from Maura Winton from the Tyee. What do you see as the biggest challenge to BC responding adequately as you call for with this new variant? I'll let you take that first.
The toolbox is the toolbox to me. And I think one of the difficulties we've had so far is we've been fighting this with one hand tied behind our backs. We didn't talk about the weird success of Ontario this fall. Ontario among, the COVID-6, as we call them, Quebec, Ontario, Manitoba, Saskatchewan, Alberta, BC. Those are COVID-6, I think Lisa Iannatoni coined that one. Those are our 6 less successful provinces. Ontario was a real outlier this fall. It started to climb a bit in terms of cases, but we project a very benign fall wave for Ontario right now. I think a lot of that has involved using available tools that depend on understanding the science. And it's been a fight in Ontario to get people to say the A word, to say airborne. That said, in some really big jurisdictions in Ontario, like Toronto District School Board, we've had a HEPA air cleaner in every single classroom. It's hard to know, is that causal? Is that not causal? I don't know. But wow, Ontario did a lot better with a fall Delta wave than I think we could reasonably have expected. We kept kids in masks. The kids are fine with it. It clearly helps a lot. And if you're talking about an aerosol disease, that's protecting people in both directions. I think particularly in some of the more populous health units, there's been incredible sensitivity, and I'm sure this is the case in BC too, to cultural issues around vaccination and to reaching out to populations that might have challenges in getting vaccinated. And I've been so impressed. I have a marvelous colleague here in Toronto named Andrew Boozery, who's a worthwhile Twitter follow. And Andrew has been absolutely amazing about figuring out how to do vaccine clinics that meet people where they're at. And in as much as we really have had a socioeconomic gradient in risk, and in as much as under-vaccination tracks on income, so the lower you go, the more likely people are to be under-vaccinated. That's probably been very, very important for us. So I think moving forward, the cards were dealt, or the cards were dealt. It's not like, maybe in 3 months, Pfizer and Moderna will have an Omicron-tuned vaccine, and we'll all be getting vaccinated again. I have no idea. But there's a lot that we can do with the tools that are already in our toolbox. Honest, transparent, science-based public health messaging that, just like Dr. Tam did on November 4th, tell people this is like infectious cigarette smoke. It spreads through the air. Here's how you protect yourself. What would you do if you were near a smoker and you didn't like smoke? You'd crack a window. You'd take a few steps back. People in BC have experience with smoke coming from wildfires, and N95 masks work very well for that kind of smoke, and they work very well for infectious smoke too. HEPA filters are fantastic. And we know from US schools that when you put HEPA in combination with improving ventilation, even by just cracking doors and windows, you reduce transmission by 50%. HEPA and opening doors and windows does nothing to large droplets or contact in a classroom. Kids don't touch each other less because there's a HEPA filter in the room. So this is all aerosol. So got to get kids vaccinated, get the grown-ups boosted, and reach out to hard-to-reach communities and really start using the aerosol stuff to keep people safe.
Thank you. I also would add rapid tests for BC. We have not had access publicly to rapid tests. The publicly available, I know they're available for some businesses that can apply for them, but on the whole, it becomes an equity issue that those who are able to afford the shipping from wherever, we don't have accessible pharmacies that pay that you could buy them. So it becomes an equity issue that those who can afford it, those who have access to, knowing that it's important and can be a useful tool to keep people safe in gathering, are able to use it. But we really need this to be, widespread, similar to Nova Scotia again, especially with indoor gatherings with winter and the holidays. That would be my addition to the answer for Maura. So the next question she has is the public as pandemic fatigued as they make BC out to be, or does vaccination mean we are protected? And what are the stakes of waiting right now?
I'm not.
So I think there's this general sense in BC that the pandemic is over for the most part. And so, is there a sense that, is it right or wrong, but also is there too much stake on the vaccine as being as protective as it may not be or may be? What are your thoughts on that?
So what we can see is that the vaccines work awfully well. Even when they fail, they work well. The vaccines work in a bunch of different ways. They prevent people from getting infected in the first place. If they get infected, they get less sick. They shorten duration of shedding of virus in people with breakthrough infections, so that in as much as how many people you infect depends on how long you're infected for, that reduces transmissibility by somewhere between 30 and 70%, depending on the study. So vaccines do a ton. What you're going to see in a majority vaccinated population with imperfect vaccines, you've got 80% of the population vaccinated, you're going to see a substantial number of infections in vaccinated people because they're the majority of the population. So per capita risk may be much higher in unvaccinated individuals, but you're still going to see a substantial number of infections in vaccinated people. And I think that gets sort of spun in interesting ways by opponents of vaccination. I think we are all exhausted. I think we all do want this to be over. I think the important thing is that you can't unilaterally, Alberta sort of showed us this. And Austria has just showed us this these last couple of weeks. You don't unilaterally declare the pandemic over and think that the pandemic's over because you said it is, right? The virus has a say too. I think what's really important that Amy said is that lockdowns now are failures. Lockdowns represent policy failures. Because if you're locking down because you crashed your health system into a tree, what that means is that upstream, you didn't take the prudent, proactive steps. You didn't use the science to prevent things from getting to that point. You didn't have the courage as a leader to prevent things from getting to that point. So you failed. There's been some really wise colleagues who've, pointed out the parallels between learning that this is airborne and using the tools that we have. We know how to deal with hazards in the air. Industrial hygienists have been thinking about this for years, right? We have the tools to deal with this. It's very much analogous to late 19th century where there was a paradigm shift from, cholera and typhoid are spread by bad smells to cholera and typhoid. Now we have the science. We know they're actually tiny particles in the water. And if we drink water that has tiny particles that come from other people's poop, we're going to get sick. So what do we do about that? Now that we understand the science, well, we filter that water with sand, filtration. And then we chlorinate, right? We add a little bit of chlorine to kill the little bugs that get through the filter and say, yay, I made it. You kill them with chlorine. And what you saw in Canada at the turn of the last century is typhoid, for example, in my city in Toronto, went from being the #1 cause of death to a rarity, right? You look at cholera in Montreal in 1832 when it first broke out and devastated the city, to 2010 when there was a big cholera epidemic in Haiti and there were cases imported into Montreal, which of course has big Haitian community, and there were dead-end cases because we built the infrastructure based on the science. So Montreal has sewage treatment, water treatment. Cholera is not an issue anymore. we have to move to that kind of thinking with airborne infectious diseases. There are a number of fringe benefits, especially in schools. We know test scores go up in kids
Right.
who learn in well-ventilated environments. You're taking out particulates as well as taking out viruses. We know there are bad health effects with kind of small sooty particles, PM 2.5s and PM 5s and PM 10s. They're associated with cardiac disease, they're associated with stroke, they're associated with
Right.
arrhythmia. We're taking out all this stuff that we shouldn't be breathing. And so I think there's the potential for some real health dividends there that extend well beyond the pandemic. I mean, one of the really interesting recent arguments I've heard from folks in infection prevention and control is, well, you say that the fact that there's pre-symptomatic transmission of COVID and COVID spreads better indoors, you say that that's an argument in favor of aerosol, but there's pre-symptomatic transmission of influenza and influenza spreads better indoors. Well, it's like, well, maybe COVID's not the only thing that's been labeled a droplet-borne disease, but that's actually airborne. So we actually sort of have an opportunity here to improve health and as I say, improve education, but we have to follow the science where it leads and not say silly things just because it's inconvenient and we don't have the, enough negative pressure rooms in a hospital. So we're going to say this is droplet borne because we can't use our usual protocols.
But there are tools that are widely available. We produce nationally now in-house Canadian N95s, and they're not selling, because their hospitals aren't taking them up on them. So it's, we're not asking for the world really. We're asking for tools that are there: HEPA filters, N95s, open windows if you can. And we're not even asking for revamping of HVAC systems because we know that's just going to be too costly and too time consuming. But there are quick and not inaccessible fixes that we can start right away.
Right. Absolutely.
Yeah. Okay. So we have just a couple more minutes, but I'm just wondering, we have one last question from Twitter from the public, and it's really about the immunocompromised population. Are there extra measures they can take right now with the new variant coming, with the fact that, the messaging, as we've talked about, has been very confusing? Some of these immunocompromised patients, they're tweeting from their hospital rooms that they're feeling unsafe. Do you have any advice for patients who really, are bearing the brunt of this, as we've talked about with, socioeconomic status, immunocompromised state, the most vulnerable in populations?
I don't have anything brilliant to say. I think that there are two things. One is one of the real disappointments in terms of Canadian infection prevention and control has been, it seems to me, a greater focus on not admitting error than on protecting patients. And if you are in a healthcare environment, you can't do it alone. A lot of this stuff you can't do by yourself. I think well-fitted masks are really helpful, and N95 masks that don't have gaps are helpful and should provide a high degree of protection. I think getting vaccinated is important, but also, one of the difficulties with vaccines is the people we most want to protect often have the least strong vaccine responses, which is really why we need sort of collective, communal action on getting vaccinated so that we protect people with immune compromise, both directly and indirectly. Lastly, and this is I just want to add this, there's been this stuff about Omicron must have emerged in someone with immune compromise. I think absent positive proof of that just sounds like hooey. This thing is totally drifted off from the pack in terms of how genetically different it is. We've not seen a single instance of something like this happen in a documented case in an immunocompromised individual. We've seen some emergence of slightly different variants in people who have been on monoclonal antibody therapy, but we haven't seen something suddenly, diverge and become, COVID 2.0. And I think nonsense like that really does a huge disservice to folks, the many, many folks who live with, chronic health conditions that affect their immune systems. I don't think that's fair at all.
Right. No, thank you. And thank you for making that point. That's really important. And I think, you touched on a really important thing, which is I think there's not much more that the individual person who has immunocompromised can do. It really is a collective effort. It really is why the public need to all be empowered to do our part and to bring down transmission in the community, so that in turn, those who are made most vulnerable by society already are then also protected. And I think that's a really key message as well that I took from what you said. So thank you so much for that. So we are out of time. That flew by. I really want to thank you so very much for your
Thanks for
candor.
inviting me.
And this was a great conversation, and we hope that it helps BC kind of understand your take on things and our take on things with regards to how to keep things safer. And be sure to tune in to our social media. We will be talking about holiday tips for safety. And until then, we'd like to say thank you, and please stay safe. And remember, COVID is airborne.
Be safe, everyone. Take care. Thank you again, Amy.
Thank you so much.
Bye.